Hello, this is Katie Bodine speaking, and we are going to be discussing hypothyroidism today. As we go into our talks about endocrine abnormalities, it is important to remember your pathophysiology. The thyroid system luckily has a very straightforward circular feedback mechanism, so it is fairly easy to remember. The thyroid releasing hormone from the hypothalamus stimulates the thyroid stimulating hormone to be released from the pituitary, which stimulates thyroid secretion of T3 and T4. 85% of the body's T3 is actually produced by peripheral conversion of T4 to T3. So what's primarily secreted is, in fact, T4 and a very small amount of T3. It is important to remember that circulating thyroid hormones are 99% bound to serum proteins, principally the thyroxine-binding globulin, TBG. So only the free form of a hormone is active at a cellular level. Therefore, if you have a patient with a condition that's affecting protein binding or they're significantly malnourished, your levels of T3 and T4 may be relatively uninterpretable. Both T3 and T4 come back and have both a direct and an indirect feedback mechanism to support your TSH. This is from Up to Date. It's a nice picture of the feedback mechanism in your thyroid regulating systems. In terms of hypothyroidism, most ambulatory patients with thyroid function have a normal hypothalamic pituitary axis, okay? Primary hypothyroidism, that is going to be 95% of these patients. So it's very rare to have secondary or tertiary hypothyroidism. So patients presenting with hypothyroidism have a low TSH. This a low TSH indicates thyrotoxicosis, so hyperthyroidism, and a high TSH indicates primary hypothyroidism. Okay, the brain says, I need more T4. The thyroid is not putting out that hormone because it's dysfunctional. So again, it's a great minority of patients that have a disease mediated by a pituitary or hypothalamic dysfunction. We're thinking tumors and abnormal things here. So let's begin with a case. We have a 50-year-old housewife. She comes in complaining of progressive weight gain of 20 pounds in the last year despite exercise, and she's concerned with her hair thinning. Her review systems is positive for fatigue, memory loss, slow speech, deepening of her voice, dry skin, constipation, and cold intolerance. Her physical exam reveals her to be a little bit cold. Her temperature is 96.8. Her pulse is 58. It's regular. And her blood pressure is normal. She's noted to be not moderately obese and speaks slowly and has a puffy face with pale, cool, dry, thick skin. Her thyroid gland is not palpable, and her reflexes are a little bit slow. So you are doing a routine visit today. This is her annual. You're going to screen for anemia, given her weight gain and hair thinning. You could do a white blood cell count. Again, you're screening, your annual screening. So, but you go ahead and do a TSH with a reflex to T4, and it comes back that her TSH is elevated at 25, and T4 is very, very low. So, what is your diagnosis? TSH is elevated. It's telling the thyroid it needs more hormone to be put out there. It's not getting any feedback. The thyroid is not putting out. You are hypothyroid. So easy, isn't it? As far as epidemiology and prevalence, this common problem affects women more than men, Caucasians, and the elderly. It affects about 1% of the general population, about 5% over 60 years old. again, this is very predominantly female problem. You'll see that with the thyroid toxicosis as well. The NHANES survey found about a 93% incidence of these patients having overt hypothyroidism, and in the Framingham study, actually, about 6% of women, and again, mostly women over 6 years old, had an elevated TSH of over 10. Etiology, again, the most common things are common. It's an abnormality with the thyroid gland itself. This is 95% of your cases. This is common. It's common worldwide, and it's due to iodine deficiency outside of the United States. This can involve genetic defects, tumors, vascular, can have empty cella syndrome, or tumor, inflammatory, infiltrative, iatrogenic, post-traumatic, after a thyroidectomy. It can be drug-related. So when you're gathering your history in these patients, make sure you're paying close attention to the past medical history, their medications, family history. All of that is extremely important to gather. So risk factors include being female and being older than 6 years old. Also, a family history of autoimmune disease. Remember, Hashimoto's thyroiditis is one of the leading causes of hypothyroidism. If they've had previous head or neck irradiation, that thyroid is no longer going to be functioning. Also, if it's iatrogenic, it was injured during surgery, or if they had hyperthyroidism or Graves' disease and they had removal of that thyroid gland, they are now going to be hypothyroid. Treatment with common medications as a risk factor. If a patient is on amiodarone or lithium or interferon alpha, they need to be routinely screened for hypothyroidism. Certain genetic syndromes such as Downs or Turner's, and other autoimmune states. Common associations with hypothyroidism and diabetes, anemia, primary adrenal failure, myasthenia celiac. So there's several common disease associations that if your patient has a history of, you should be thinking about getting a TSH if their physical exam and history warrants. And as far as the diagnosis goes, we are going to have a usual approach to our history and physical, keeping in mind their chief complaints and their review systems in guiding our diagnosis. The symptoms can be subtle. They can also expand virtually every system. So just think low and slow, okay? So depression, low or hoarse voice, sleep apnea, they're tired, they're constipated, they can have paresthesias, slowed thinking, feeling fuzzy, cold intolerance, fatigue is a big one, weight gain. These are a couple pictures I thought were helpful. There is a website I put here down at the bottom. It's called Educate, Innovative Research and Design, and they help go through straightforward cases and it's evidence-based, and they have some lovely pictures, as you can see here. It's very helpful to remember all this information you're trying to swallow, okay? So physical exam findings, classic for hypothyroidism. You may or may not palpate a goiter, especially in a younger female. The anterior tibial non-pitting edema. You'll find hair loss. You see these legs over here have no hair. This lovely lady here is classic, has the lateral loss of her eyebrows. She's got sparse lashes and hair, dry, coarse, thick skin, Also on your vital signs, mind your bradycardia and your blood pressure measurements. In addition, make sure you do those deep tendon reflexes and evaluate for peripheral neuropathies. Our differential diagnosis is going to include depression. You might want to include a screen here. It's a comorbid condition as well. They could have CHF with the edema, thyroiditis. They could be presenting in that phase of hypothyroidism. Euthyroid syndrome, adenomas. That most of these are going to be slightly lower down on your differential, but always important to keep in mind. As far as the diagnostics goes, very straightforward. I thought this table was helpful when you are ordering, particularly with EMRs these days. If you put in thyroid, there may be an abundance of different tests that you can order. A lot of times it'll say TSH assay, or it'll say TSH with reflex to T4. That's a money-saving move. You don't want to just be getting T4s all the time. If their TSH is normal, most likely you don't need a T4 or a free T4. That's an extra step, it's an extra cost. So you are going to send a TSH, and if it has a red flag to it, it'll automatically add on a T4. Some cases you may have to order them separately, but a high TSH, low free T4 is the pattern associated with primary hypothyroidism. A level greater than 20 is most likely to present with significant hypothyroidism. You're going to be seeing physical exam changes in vital signs. Your patient doesn't feel good. And a low T4 just confirms the hypothyroidism and helps to define the severity. Imaging is generally not necessarily unless you find a nodule on physical exam. Remember that Hashimoto's thyroiditis, the precursor to hypothyroidism, if a nodule is present, it has about a 9% prevalence of papillary cancer, so do not forget to ultrasound these people. Just note here, routinely, a T3 should not be done to diagnose hypothyroidism. That is for hyperthyroidism. Okay. Here I've just provided some examples of laboratory diagnostics and how to interpret these. Euthyroid syndrome, you're going to notice that the TSH is normal and you have a decreased free T4. So T4 is not high. There is some controversy whether to treat this or not. However, we'll talk about that later in the lecture. As far as interpreting your results, just keep in mind that some disorders may alter your lab results. If they're severely ill, if they have protein-calorie malnutrition, pregnancy, nephrotic syndrome, hepatic failure, those are going to alter your ability to hold on to your protein. If they have antithyroid antibodies, they may define the cause of the hypothyroidism. You may be wanting to figure out if this is Hashimoto's or another autoimmune process. Remember your patient's socioeconomic status as well. If they're paying out of pocket, you might not need to send antibodies because it's not going to change their outcome. You're going to treat their clinical hypothyroidism, and with a relatively inexpensive marker is the TSH, and so it might be helpful once they have funding, but at the time maybe try to just save them some money. As far as drugs that can alter lab results, very commonly patients are on dilantin, amiodarone, dopamine agonists such as Reglan, aspirin, estrogen supplements. Those can falsely increase the TSH, and there are some drugs that can decrease the TSH, especially if they're taking their wife's thyroid supplements, or if they're on some sort of steroid, if they're on dopamine or octreotide, those would be red flags. Drugs that can increase the T4 are heparin, and if the patient's taking high doses of biotin, so make sure you're asking if they're taking specifically any herbal supplements. There is some controversy over whether to screen routinely for hypothyroidism. Of course, you are the provider and you're going to use your judgment if a patient has risk factors and laboratory imaging that lead you to need a TSH. Feel free to order it, okay? Screen them. Pregnancy, if they have a history of thyroid disease or family history, you should be screening them. However, universal screening has been not recommended for patients that are pregnant just because they're pregnant or planning pregnancies. The USPSTF has found insufficient evidence for or against screening in non-pregnant asymptomatic children and adults. All neonates are screened. It's mandated by law. It's crucial to figure out if they have congenital hypothyroidism, and so that they may be treated aggressively to avoid defects. And as you can see, the different expert groups have different opinions. The AAFP, they're against routine screening in asymptomatic adults under 60. The AACE recommends screening older patients. They do not really define on the age. The College of Obstetrics recommends women with a history of autoimmune disease or strong family history starting at age 19. As far as treatment goes, it's fairly straightforward. This prognosis is good if you can maintain adequate follow-up. Is a daily dose of thyroxine, T4. Synthroid is the most common brand, and I want to emphasize that brand matters. Okay. Usual dose is about 100 mics per day. This can range from 25 to 200. This can be supplemented in IV form if they're NPO for a long time. Although the half-life is pretty long, so if they're inpatient for a few days and they miss a couple doses, it's unlikely to present a clinical harm. You'll replace them at 1.6 mics per kg per day. If they're older, you want to start at a lower dose. Go start low and go slow. And it's pretty important to take it on an empty stomach. And as you know, if your patient has hypothyroidism, they probably have other comorbid conditions. So make sure that they're not taking their supplements with this because it can inhibit absorption. Very common things like iron or calcium, okay, or PPI. You want to measure their TSH in another 6 to 8 weeks and make your adjustments as needed. And our goal is to maintain a euthyroid state. So once the TSH is normalized, how often do we do it? You could bring them back every 6 months or annually. Do note that central hypothyroidism, so if they have a pituitary adenoma, history of empty stellate syndrome, they're maintaining lifelong endocrine therapy. A TSH is unreliable, right? It is a secondary, it is a central cause, therefore we know that gland's not putting out properly, and we're supplementing T3 and T4, so we need to monitor with the actual thyroid hormones. Educate your patients. Unfortunately, people with poor access to healthcare are going to suffer because they may not be able to afford their medication. It needs to be made very clear that this is lifelong, and if they do nothing else, they need to seek medical follow-up so that they can get their prescription for this. As far as some treatment pearls, like I said, branding matters. Stick with the same brand. And if your patient has a change in funding, perhaps you need to change over to a generic. Measure that TSH 6 weeks after the manufacturer switch, because there is difference among brands, okay? It's always a good goal to have a patient euthyroid prior to an elective procedure. If you have a patient you know is hypothyroid, get them checked out, do their pre-surgical assessment. With known coronary artery disease, start extremely low. You do not want to create hyperthyroid or thyrotoxic state, which could drive them towards having an MI. Monitor medications that they are also taking. There was a recent meta-analysis of controlled trials comparing the use of combined T4 and T3 to T4 alone. There was no difference in depression, fatigue, weight gain, cholesterol levels. So they concluded that T4 alone is the treatment of choice for the vast majority of patients. It's more physiologic. Remember that we will convert as needed to T3 in our peripheral tissues. There is controversy, again, over subclinical hypothyroidism. If they're not having clinical symptoms, why should we treat it? There was a Cochrane review that found no improvement in survival or cardiovascular morbidity or health-related quality of life. However, there is some evidence that indicates improvement in lipid profiles and ventricular function. So the current recommendations are to treat if they have iron deficiency anemia or if they have a TSH greater than 10. As far as pregnancy considerations go, untreated hypothyroidism in pregnancy is associated with increased spontaneous abortion, fetal mortality, and low birth weight. So if they have an established hypothyroid condition, you need to anticipate that they're going to have an increase in their T4 dose requirements. You're going to be checking them in the first, second, and third trimesters and postpartum periods. And painless subacute thyroiditis in a patient who has not previously had a diagnosis of hypothyroidism can occur. And it's a period of transient hypothyroidism, so it can last 3 months, and we'll be discussing this further in our thyroiditis lecture. As far as complication goes, mixed edema coma is your big red flag complication. The people at risk for this are people who have had long-standing hypothyroidism. They have poor access to care. They have comorbid or concurrent illnesses. They got a UTI, and so their hormone levels are stretched, or they have adrenal cortical issues. These people get really sick and they can die. So the mortality rate's 30 to 60%. It's a true emergency. They're coming into the ER cold. They're bradycardic. They're altered. I had a patient with this. I was she actually had a kind of a hypothyroid psychosis and did not have primary care doctor, kept presenting to the ER every few months, not feeling good, kind of getting worse. They never figured out. They told her she had a UTI a few times. They sent her home. Eventually she came in a mixed edema coma. She ended up trach-pegged. Took her months to get better. And she was not happy that they missed this. But I personally have to say we don't usually draw a TSH in the ER because it takes so long to get back. And when a patient doesn't have follow-up, we generally recommend that they follow up with their doctor. So it was a really unfortunate situation. Do your best not to let your patients get there. The treatment is ICU care, most likely going to need airway protection, intravenous thyroid hormones. They're most likely going to benefit from additional steroids. They're likely adrenal insufficient at this point, and you're going to treat any other conditions you've found, such as infection. As far as complications go, you can imagine if this is affecting every body system can have complication if this goes untreated. Megacolon for ongoing constipation. These people are going to have an increased susceptibility to infection. You can have sexual dysfunction, organic psychosis, like my poor patient was told she was crazy and kicked out of the ER. Infertility. This might be a reason to screen for your TSH in somebody who's unable to get pregnant. AFib and osteoporosis can occur in the elderly when you've given them too much medication and they have iatrogenic thyrotoxicosis. Again, your patient population with coronary risk factors can have treatment-induced congestive heart failure if they're treated too aggressively. Well, that's a lot. If you really understand the access, you don't have to memorize these things. It's straightforward, it's common, it makes sense. Your common things are common, so your Hashimoto thyroiditis, if you have a patient you've diagnosed with that, be on the lookout for the development of hypothyroidism in the long term. Your common symptoms, just remember, slow, they're fatigued, they're cold, they're constipated, they're gaining weight, they're depressed. You might have heavy periods in females, a reason to treat that sick euthyroid state. They're becoming anemic because they're having menorrhagia. Common signs, again, that goes along with it: dry skin, slow heart rate, slow tendon reflexes. Free T4 will usually be found low if you choose to draw that, or if you have a reflex with an elevated TSH. Always remember that your pregnant patients need to be monitored, and dose adjustments will need to be made throughout their gestation and postpartum course. And avoid overtreatment in your frail patients, your elderly, your known cardiovascular risk patients. That's it for today. I hope you have a good one, and let me know if you have any questions.